Good afternoon, everybody. Today we'll start lectures that called urolithiasis or urinary stone disease. You know that this disease is widespread in many countries around the world. We meet it almost equally in America, Africa, and Europe. Urinary stone disease continues to occupy an important place in everyday urology practice. The average lifetime risk of stone formations has been reported in the range of 5 to 10%. A predominance of men over women, if we compare approximately 3 to 1, can be observed with an incidence peak between the fourth or fifth decade of life. Recurrent stone formation is a common problem with the types of stone and therefore an important part of the medical care of patients with stone disease. There are three main series: nucleation series, stone matrix series, inhibitor of crystallization series. Most investigations acknowledge that these three series describe the three basic factors influencing urinary stone formations. It is likely that more than one factors operated in causing stone disease. A generalized model of stone formations combining the three basic series has been proposed. We know from the epidemiological factors that men more than women. If we compare in the different countries, for example in Germany, we find more than 4% of populations. In Ukraine, maybe 5 to 6%, but we have in Ukrainian country also specific regions that the percent of patients with stone formation more in the other districts. For example, in Ternopil, Lviv regionals, the rate of these stone formation patients more than the other place. Maximum rate at 30 to 50-year-olds. In children, rarely. Geographic and ethnology, it's independent. From the etiological factors, we divide to the disorders of urinary tract, liver and digestive tract disorders, endocrine disease, infectious focuses of the urogenital system, metabolism disorders, injuries also leads to continuous immobilizations, climate and geographical cause, and others. For example, what include disorders of urinary tract? It's a congenital abnormalities, those favored to epistasis, obstructive process, neurogenic dyskinesia of urinary tract, inflammatory and parasitological damage, foreign body of urinary tract. For example, we suture urinary bladder but non-absorbable material. After some period, after 1 year, 2 year, crystallizations, and we will have stone in the urinary blood. Liver and digestive tract disorders. It's some problem with the hepatogenic gastritis, colitis, and others. Very often we find stone disease if you have endocrine disease. Hyperparathyroidism, it's a problem with the phosphocalcium, hypothyroidism, the hypopituitary disease, metabolic disorders. For example, prolonged immobilizations, fracture of the vertebral column and limbs, osteomyelitis, disease of the bones and joints. In the North country, we rarely that we find stone disease in the north. It's the Africa country where we have dry and hot climate with a high vaporization, decrease of water supplies. It's the level of the stone formation in more. Iodine deficiency, disorders of nutrients and vitamins balance. It's also independent from the factor that cause to the stone disease. Risk factors. If the start of disease early in life, less than 25 years. If you have stone-containing brushite, only one functional kidneys, disease associated with the stone formations, hyperparathyroidism, renal tuberculosis, jejunal bypass, Crohn's disease, intestinal resections, malabsorptive conditions, sarcoidosis, and others. Also, to the risk factors, we have medication associated with the stone formations. For example, it's calcium supplements, vitamin D supplements, anatomical abnormalities associated with the stone formations, tubular ectasia, pelvic-ureteral junction obstructions, callus diverticule, callus cyst, ureteral structure, vesico-ureteral reflux. For example, abnormalities that called Horschel kidney, ureterocele, and others. In this picture, we can see coral stones situated in the all pelvic systems. If we have problem with the parathyroidism, problem with the calcium-phosphorus change, and we will have a big stone that first of all situated on the all pelvis after the big calytus, and on the third stage that situated not only big but in small calyces. What's the type of the kidney stone? There are three basic kinds of the kidney stone: calcium stone, uric acid stone, thyroid stones, and cystine stones. It's different from the color, it's different from the structure. Some doctors have the good practical. Sometimes if they remove the stone, suspect that it's a dark color, it's a hardly concentrate, it's a oxalate. Urate stone, it's a brown color and in different consistency. Uric acid stone, it's a non-radiopaque stone that we cannot see on the plain field. Diagnostic images. What include diagnostic images? It's a main complaint, it's anamnesis of the history, it's also objective examination from all organs and systems, is additional methodical that we use from the diagnostic program. A personal as well as a family history should be obtained for all patients. It's the history of inflammatory bowel disease, recurrent urinary tract infections, prolonged periods of immobilizations, gout, or familial occurrence of certain inherited renal disease, renal tubular acidosis, or cystinuria should be sought. If we have renal colic, we have acute obstruction. Because what is it, a renal colic? It's problem with the output of urea, and we have complete block. A form of severe abdominal pain, often accompanied by the nausea and vomiting due to ciliary ganglionation stimulations, onset and sudden, often during the night or in the early morning. Obstructive calculus in the upper urinary tract caused to the extreme crescendo-like pain in the flank that generally radiated laterally around the abdomen to the corresponding groin and testicle in the male and to labia majors in female. But if the stone spontaneously passes through the pelvis to the ureter, for example in the mid-ureter, the pain tends to the radiated to the lateral flank and abdominal regions. However, when the obstruction is in the distal ureter, in this picture we can see near the ureterovesical junction, the patient exhibits symptoms of bloody urtications. It's a frequent urinations, difficult urinations, small portions of urine, and also irradiation to the glands, penis, and testes in men, and the labia majors in females. Fever is rarely present except when a urinary tract infections accompanies obstructions. Pulse rate and blood pressure, however, may be elevated as a result of the pain and agitations caused by the renal colic. The patient's abdomen is generally flat and soft, with a moderate deep tenderness on palpation, so while the calculus is enlarged. Some patients also have extensive hyperesthesia of the abdominal wall, either anteriorly or posteriorly. The costovertebral area may be tended to percussions. You know from the therapy surgery that if we use percussion of the limbo regions, it's called symptom bypass Tarnatsky. In all cases, we have positive symptoms of bypass Tarnatsky. Laboratory investigations, blood analysis, level of calcium, albumin, creatinine, urate, because if we have complete block from the both sides and we will have post-renal anuria, the level of urea and creatinine increase. If we use biochemical analysis, we studied water level creatinine and urate. If you remember, normal creatinine 8.3, urate 1.0, but the level this creatinine and urea increase. Also, urea analysis we use leukocytosis, bacteriuria, cystinuria, calciuria, uraturia. It's independent from the what pH of our urea and to what type of salt we find. In the urea analysis, we have leukocyturia, bacteriuria, proteinuria, micro or macro hematuria. Ultrasound investigations. In all cases, we use this method. It's a non-invasive method in patients in whom it is not possible to obtain an intravenous urography or CT with the contrast. Ultrasonic evaluations of the kidneys may be aid in the diagnosis of the renal stone. Also, for example, we have pregnant women with a flank pain in whom it is desirable to limit radiation exposure, or in anuric patients or patients with a chronic renal failure, the presence of the hydronephrosis on acoustic shadowing may be diagnosed. We use this method and we find where situated stone, what size of this stone, if we have dilatations, if we have complete block or not, because if the stone situated, for example, in the piloureteral junctions, we will have enlargement calicopelvis systems. For example, in this picture we can see stones situated in the kidney, small dilatations calicopelvis systems. For example, we use ultrasound investigations, stone situated about 1 cm in the greater diameter, situated in the middle part of the ureter, and we can see dilatation the ureter. You remember the diameter of our ureter 4 or 5 millimeters, but it's in the situations we have 10, 12 millimeters. That's why we have complete block, and also it's called ureterohydronephrosis. It's tactic indication to mini-invasive or operative treatment. Next step from the diagnostic include X-ray investigations. For example, first of all, we start from the plain film or KUB, kidney ureter blood. If we have radiopaque stone, we can see where situated the stone. For example, in this situation on the plain film, we can see stones situated in the pelvis, left kidney, and small stone maybe in the lower part of the lower calyces. In this picture we can see a big coral stone situated in the right kidney and formation the stone in the lower calyces. Plain film. The doctor passed catheter, but catheter stopped before the stone. For example, we have renal colic without effect from the conservative treatment. And the next step is catheterization of the kidney, but the diameter of the stone very big and the catheter stopped before. And in the middle part we can see stone maybe 2 to 1 centimeters. Next, continue. Plain film. Very big stones are situated in the lower part of the ureter, in the right ureter. Plain film. Stones situated in the right kidney. In these situations, we can see catheters that stop in the kidney, situated in the calicopelvis systems, but in the lower part we can see catheter, we can see stone in the lower part. Plain film, coral stone is the both kidney, and very big stones situated in the urinary bladder. The plain film if we have radiopaque stone, but I said that 30% of all stone it's a non-radiopaque. That's why we cannot see on the plain film. Only ultrasound investigations, only CT, only excretory some specific symptoms we can see. Next step, from the studied anatomofunction ability, we use excretory urography. First of all, we use sensitivity to the iodine test, 1 milliliters contrast materials. We introduce 40-60 milliliters, 66% contrast materials, urographene, varographene, trionblast, and others. And after 5-7 minutes, we will start investigations. We will see methodical how we use. And for example, in this picture we can see filling defect, maybe in this part situated stone. Also filling defect, very big stones are situated in the pelvis. Also we diagnosed that the cause of the stone formations may be stricture piloureteral segments and dilatations calicopelvis systems. Pyeloctasia, dilatation of the pelvis. If the level creatinine more than 200 micromole or 0.2 millimole, if we have sensitivity, if we have some problem, it's contraindication to these investigations. If we have chronic or acute renal insufficiency, and if we have allergical reactions from the contrast medium. If we have contraindication to excretory or we haven't diagnostic from the excretory, next steps we use pneumopylography, retrograde pneumopylography, or if we have non-radiopaque stone. For example, first of all, we use catheterization of the kidney, and next step we introduce oxygens. You can see in this picture it's a retrograde pneumopylography with diagnosis non-radiopaque stones situated in the pelvis. In this picture we can see stones situated in the upper portion of the right ureter. Retrograde pneumopylography, it's a dark color, it's a ureter to the pelvis. We introduce oxygens, and from this dark color we can see shadow suspected the stone. In the upper portion of the right ureter we diagnose the stone. And for example, in the middle part of the left ureter, it's a dark color, it's oxygen. We diagnose this non-radiopaque stone. Antegrade pyelography. First of all, we use percutaneous nephrostomy, and after that we introduce contrast material or oxygens. This methodical is called antegrade pyelography. And for example, if we suspect non-radiopaque stone in the urinary bladder, we introduce oxygen to the urinary bladder. First of all, catheterizations of urinary bladder. Introduce 200-300 milliliters oxygens, and from the dark color we can see shadow suspected the stone. A big stone is situated in the blood. Okay, continue. Next step is the endovesical examination. If we suspect stone in the urinary blood or in the intramural part of the ureter, we use cystoscopy. This situation shows the swelling of the ureter orifice. If the stones stop in the intramural part, we can see enlargement of the orifice, edema, and stone that pass to the orifice. Small stones are situated in the urinary bladder. CT. In this picture we can see good informations where situated the stone. Expensive method, but sometimes help to take correct diagnosis. For example, left side hydronephrosis, we use with the contrast materials. The stone blocked uretero-pelvical junctions. And complications, hydronephrotical transformations. We can see thinning parenchyma, maybe sad stage of the hydronephrosis, maybe indication to nephrectomy. It depends of what the thinning parenchyma. Differentiated diagnosis. We compare clinic, we compare additional methods. In all cases, in the all urology symptomatic, for example, if we have tuberculosis, tumor, trauma, if we have congenital abnormalities, nephroptosis, hydronephrosis, in all cases we have pain in the lumbar regions, we have problem with the urinations, we have in the urinalysis proteinuria, bacteriuria, leukocyturia. That's why we use additional methods. For example, on the excretory urography, we can see hydronephrotic transformations. We can see filling defect, calyces, and pelvis. It's a papilla cancer. Nephroptosis, moving our kidney, non-physiology excursions. Stricture dilatations destroyed the calyces specific from the tuberculosis. Filling defect specific from the stone. And trauma of the upper portion of the upper calyces. Treatment. We divide to the conservative treatment, instrumental or mini-invasive, and surgical. Surgical we also divide to the mini-invasive, also open operations, and sometimes if we have complications such as pyonephrosis, sad stage of the hydronephrosis, we remove kidney and we use nephrectomy. Pain relief involves the administrations by various routes of the following agents: diclofenac sodium, indomethacin. We introduce some spasmolytics, for example, Baralgin, Noshpa, Noshpa Forte, Tramadol, Spasgan, Renalgan. We introduce intramuscles or intravenous by the physiology solutions. All sometimes we prescribe on the oral, in the table. Warm bath because hot, spasmolytic effects. Spasmolytic cocktails with the papaverine, spasmalgon, noshpa, promadol should be taken. A higher dosage of the cystanol or urolithin, 20-25 drops on the piece of sugar, is the ratio factor in the start of the renal colic. In egg doesn't disappear, the Novocaine blockage of the spermatical cord in males and around ligaments in the females is required. Physical methods. We prescribe amplitude therapy, diodynamic therapy, ultrasound stimulations, and others from the remove the obstructions. If we have pain and not effect from the conservative treatment. It's indication to the instrumental methods, to the catheterization of the kidney or percutaneous nephrostomy. If we have stone and we have complete block, for example, we prescribe renal gun, barrelgins, cocktail with the different spasmolytics and analgetics, Promadol, we haven't effect. Prolonged pain, vomiting, nausea, after that high temperature, it's indication to catheterizations. We take catheterization cystoscope, we find where situated left or right orifice. For example, we have from the left side, we find left orifice and pass catheter through the orifice to the kidney. That is the stone above the stone, this catheter. Or if we haven't moment from the catheterization of the kidney, it's indication to percutaneous nephrostomy. Ultrasound examinations, we find where situated the calicopelvis systems, we pass needle, after needle we use dilatation, we pass sounds, and after that dilatation from the specific instruments, and after that pass drainage through this needle to the pelvis. It's called percutaneous nephrostomy. Stone removal. It's independent from the size, shape of the stone. Spontaneously stone passage can be expected in up to 80% of the patients with a stone no larger than 4 mm in diameter. For stones with a diameter exceeding 7 mm, the change of the spontaneous passage is very low. It's independent where situated. In the proximal ureteral stone may be spontaneously passed to the 25%. In the middle ureteral stone, 45%. And in the distal part of the stones, if they're situated in the distal part, more than 70% of all cases, the stones spontaneously pass. What's indication to active stone removal? Stone removal is usually indicated for the stone with the diameter exceeding 6-7 mm. Active stone removal is strongly recommended in patients with the following criteria. Persistent pain despite adequate medications. We haven't effects from the medications. Persistent obstruction with risk or impaired renal functions. If we have, for example, one functional kidney and we have obstruction, we will have complete block and we will have in the future post-renal anuria. That's why it's indication to active stone removal. Risk of the pyonephrosis or urosepsis. Bilateral obstruction. It's also cause to the post-renal anuria. Obstructive calculus in the solitary function kidney. What is the stone removal? In patients with the coagulation disorders, the following treatments are contraindicated. If they have, because now we will stop from the extracorporeal shockwave lithotripsy, percutaneous nephrolithostomia, and lithotripsy, ureteroscopy with the lithotripsy, and others. We never use these methods if we have pregnant women. We never use if we have pacemaker. It's also contraindication to extracorporeal shockwave lithotripsy. What methodology? What is it? Extracorporeal shockwave lithotripsy. We destroyed stone, ultrasound shock waves crush stone, and the smaller pieces pass out of the body in the urine. If they destroy to the 2-3 mm from the diameter, these stones spontaneously pass through the urinary tract. And extracorporeal non-invasive techniques that use shock waves to disintegrate urinary calculi while the patient is emitted in the water bath has been tested, extended, and now in the clinical use. With these techniques, calculi in the upper urinary tract are required, reduced to the fragments which pass spontaneously from the collective systems and bladder in the most patients. Size, locations, and consistency of the stones determine the number of shocks needed in the fragmentations, generally between 500 to 2000 shocks. Sometimes we have a hardly consistent. That's why before this procedure we use CT from the started what consistence if we will have fragmentations or if we haven't, because some stones don't fragmentations. In this picture we can see extracorporeal shockwave lithotripsy. It's specific apparatus from the state 2-3,000 shockwave and destroy the small. Without anesthesia, sometimes the patients feeling small pain. It's independent from the localization of the stone. What complications? It's a cardiac arrhythmia, hematoma, infections, and colic. Rare extracorporeal shockwave lithotripsy we use about 20–25% of all cases. Next step that very good effects, it's a percutaneous procedure, percutaneous nephrostomy. These techniques urology use with the last 20 years, and it's a mini-invasive procedure within the kidney without using the standard large flank incision and mobilization of the kidney. These techniques, along with refinements in the endoscopic instruments and advanced into the fibroscopic, allows the endoscopic manipulation in the upper urinary tract by the percutaneous approach. Percutaneous nephrolithotomy with or without lithotripsy is a very good method from the destroyed of the stone. For example, in this picture we can see very big coral stone situated in the right kidney. We use nephrostomy, dilatation this site. After that we destroyed, we have fragmentations, and on the next plane film we cannot see shadows suspected the stone. In this picture we can see step by step how we use. Before operations we use catheterization of the kidney. Next step, through the catheter we introduce contrast materials. On the monitor we can see calicopelvis systems. After that the doctor passes needle from the collective systems. If we can see out urea, with dilatations through this needle, with dilatations these incisions, and after that we pass nephroscope to the calicopelvis systems, and next stop destroyed or fragmentations or remove the stone. In this picture we can see these modifications. Now we can see film, how we use percutaneous contact lithotripsy.
Most urinary stones are treated nowadays with extracorporeal shockwave lithotripsy. In selected cases, however, such as large sites and multiple stones, especially when made of hard crystals, percutaneous nephrolithotomy remains the treatment of choice. Pneumatic lithotripsy has greatly facilitated the fragmentation process. Its biggest drawback was the time required to extract the fragments and evacuate the collecting system. The combination of pneumatic and ultrasonic lithotripsy dramatically shortens this lengthy step of the procedure. The stones are rapidly broken by the pneumatic jackhammer probe, and the fragments produced pulverized by the ultrasonic unit. They are efficiently cleared by aspiration. In this video, we will demonstrate several applications of this new device.
Control X-ray investigations. You can see calicopelvis systems in the monitor.
This patient presented with a gallbone stone in the renal pelvis. Percutaneous access is obtained. The stone is readily fragmented by the combined action of pneumatic and ultrasonic lithotripters. Fragments are efficiently pulverized and cleared by aspiration. The simultaneous action of the pneumatic and ultrasonic probes avoids repetitive clogging by pulverized stone material and maintains an open lumen.
Destroy and remove the stone, the collective system.
In this particular case, total lithotripsy time was 455 seconds, a little less than 8 minutes. 3,500 pneumatic shocks were used. In this container, the typical appearance of the retrieved material reduced in fine sand is clearly demonstrated. This patient presented with a bulky stachyon calculus. Percutaneous treatment was selected.
In the calicopelvis systems, you can see catheters situated in the pelvis.
Here again, the combined action of pneumatic and ultrasonic lithotripsy is rapidly effective.
The slowly time catheter also introduce contrast material because sometimes the instruments may be passed to the parenchyma or to the other organs. Visual control.
Total lithotripsy time was 7 minutes. The patient became stone-free in one single operative session.
We pass stent from the prolonged
This
immobilization.
patient carries an impressive amount of rock-hard jackstones. Here again, the combined action of pneumatic and ultrasonic energy efficiently solved the problem. Even ureteric stones are safely treated.
You can see catheters situated in the calicopelvis system because some small piece may be spontaneously passed to the ureter from a prophylactic renal colic.
Efficiently replacing the old and time-consuming forceps extraction. In conclusion, the combination of pneumatic and ultrasonic lithotripsy greatly facilitates the treatment of large size and hard calculi. It has a preponderant position in the armamentarium of the modern endourologist as an efficient and safe therapeutic option.
Okay, what contraindication to this after this manipulation? We never use if we have hemostatic problems, if we have downstream strictures, no kidney functions, acute pyelonephritis. For example, we have complications, stone in the calicopelvic system and carbuncle of the kidney and sepsis. It's contraindication to extracorporeal shockwave lithotripsy. It's contraindication to percutaneum. It's indication only to open operations. Spine diseases, chronic kidney insufficiency in the third or fourth stage, pregnancy, tuberculosis, closed surgical procedure. If you have stone in the ureter, lower part, middle, we use cystoscopic techniques. We use ureter pyeloscopy from the diagnostic well situated, and sometimes we remove this stone through the specific instrument by the loop or basket. Visual control ureteroscopy, we find where situated this stone and remove by the specific instruments. Sometimes we pass basket and remove. In this picture we can see how we remove by the basket or forceps. Maybe if the stone situated in the lower part or middle part, we use destroyed by the electrohydraulic or the laser or the ultrasound destroyed, but very often we use laser destroyed. In Poland country very often use, for example, green laser. In Ukraine we also use laser destroyed this stone. In this picture we can see how we use these methods. Sorry. We can see stone situated in the middle part of the ureter. And first of all, we use catheterizations. You can see catheters are situated in the ureter, and contact by tip with the laser. Laser destroyed, laser fragmentations. Laser fiber, contact with the stone, and use fragmentations. It's many invasive techniques. Maybe hydraulic destroyed. In our clinic we haven't laser, we use hydraulic destroyed. But on the district hospital use laser. Some pieces were removed by the forceps or by the loop. Now we can see loop. We remove small piece by the loop. Okay, from the prolonged drainage we pass specific catheter that called ureteral stent. We can see that on the proximal and lateral positions, deviations, this tip, distal and proximal deviations, and prolonged immobilizations, 1 month, 2 months. Also, this catheter we use if we have pregnant pyelonephritis from the prolonged immobilization. Okay, sometimes we have situations that we have stone disease, for example, and attack of the pyelonephritis. Stone not very big, for example 1 cm, 1.5, it's indication to extracorporeal shockwave lithotripsy or to the contact lithotripsy. But we have attack of the pyelonephritis, a higher temperature, chills, and others. From the prolonged drainage and prescribed antibiotics, we must have 2-3 weeks or maybe 10 days. But how we use drainage? We use catheterization of the kidney, or from the prolonged drainage, we use catheterization by the stent. Now we can see a film how we use this GG stent, how we put to the kidney.
The medical term for this is a double J stent. The stent allows drainage of urine from the kidney into the bladder by temporarily relieving any blockage caused by a stone in the ureter or an internal swelling outside of the ureter. The renal pelvis is the area where the kidney attaches to one of the ureters. Urine flows from the kidney through the ureters into the bladder. When emptying your
You can
bladder,
see that in the upper portion of the ureter, near the pyloureteral segment, we can see small
this
stone.
animation shows
It
the
may be attack
blockage
of
in
the
ureter
pyelonephritis.
caused by a stone. Urine is unable to flow from the kidney to the bladder, causing congestion and sometimes pain. The procedure is usually done under general anesthesia. A tube with a tiny optic camera is inserted through the
Filling
urethra into
urinary
the bladder.
bladder, inspected
The bladder is
mucosa of the
inspected,
bladder, we find
and the
situated
urinary
left or
canal is
right
located.
orifice, and
A
after that
contrast study
pass
may be performed to
catheter.
assess the urinary tract and to locate the obstruction. X-ray images can now clearly outline the ureter and the obstruction. A so-called guide wire is introduced through the camera into the kidney. The double J stent is inserted over this guide wire. J-shaped curls are present at both ends of the stent to hold the tube in place. X-ray is used to check that both ends are in place in the kidney and the bladder. The stent is later on removed, or is sometimes used as a temporary intervention before the removal of the stone with another procedure. You will be discharged from the hospital when you have been able to empty your bladder sufficiently and you have no fever or other complaints.
Okay, thank you. Continue. But sometimes we have indication to open operations. I said that contraindication to mini-invasive, to extracorporeal shockwave lithotripsy. What indication to surgical operations? Frequent attack of the renal colic or persistent pain that disappears the patients. Disorder of urinary outflow causing the hydronephrotic degeneration of the kidney. Obstructive anuria. Frequent attack of the acute pyelonephritis. Progress of chronic pyelonephritis that caused to the renal insufficiency. Total hematuria. Calculous pyelonephrosis, apostematosis, all type of the purulent. It's abscess, carbuncle of the kidney, apostematosis. Stone at the sole kidney that cause obstruction. Stone in the ureter of the sole kidney that won't pass away spontaneously. It's indication to say. What open surgical procedure we use? Very often, if the stone situated in the pelvis, we use pyelolithotomy. Simple pyelolithotomy is used for the removal of calculus confined to the renal pelvis. Minimal dissections of the renal sinus is usually needed, and exposure of the entire kidney is not required. This procedure is not indicated for the removal of intraocular calcular stone or large branch renal calcula. We can see how we remove the stone. suture by absorbable material, sometimes we pass drainage. If we pass drainage through the pilus, it's called pilostomy. If we pass drainage through the parenchyma, it's called nephrostomy. If we have a big stone, sometimes we use incisions that called lumbotomy. In my clinic, very often we use incisions between 12 and 11 ribs to the mesogastricus. If we have a big stone that's situated in the ureter and we have apostomatosis, sometimes we use incisions and to remove the ureter. These operations we called ureterostomy, ureterolithotomy, ureterolithostomy, and others. If we pass drainage, it's called ureterolithostomy. If without drainage, ureterolithotomy. Okay, but sometimes if we have abscess of the kidney, hydronephrosis of the third stage, sometimes we remove stone. In the last century, very often, if we have choroid stone, we use incision of the parenchyma and remove the stone. These operations we called nephrolithotomy. Okay, bladder stones. The cause of the stones is different, the etiological factors. Sometimes we have very big stone, 1 kilogram, maybe it's same as a potato and other. If we compare the $1, we can see very big stone. What the stone formations? Primary stone of the bladder are relatively rare in the USA, but occur commonly in the childhood in parts of India, Indonesia, in the Middle East, and China. The stone usually occur in the sterile urine. They are uncommon in the gulls. Secondary vesical stones form as a result of the urology conditions. They nearly always occur in men and are frequently associated with the urinary studies and chronic urinary tract infections. That's why the main three theories of the bladder stone: problem with the output of urea in the lower part. For example, the patients have benign prostatic hyperplasia, compress the prostatic part of the urethra. The patient has stricture of the urethra, tumor neck of the bladder. We have problem with the output. It's cause of the stone formations. Chronic urinary stasis that cause to the chronic urinary tract infections. That's why urinary tract infection in the lower part is also cause to the and foreign body. If we have, for example, neurogenital vesical dysfunctions, it also problem with the output of urea. It's also cause to the stone formations. In this picture we can see different type of stone. We also have oxalate, it's also have phosphate, it's a white color, and urate stones. It's independent from the pH of urea. Diagnostic variations. The main complaint: very often the patient's history of hesitancy, frequency, dysuria, hematuria, dribbling, or chronic urinary tract infections. Sudden interruption of the urinary stream associated with the acute onset of pain radiations down and along the penis pain occur when the stone intermediately obstructs the bladder neck. Very simple methods, non-invasive. We use ultrasound investigation with the feeling urinary bladder. Because in the urinary bladder empty, we cannot see the oral wall, we cannot see the stone. If the urinary bladder have 200, 300, 400 milliliters urea, we can see the shadow suspected the stone. In this picture we can see stone that's situated in the side. Also we studied maybe different pathologicals, maybe benign prostatic hyperplasia, maybe thinning the wall of urinary bladder, maybe tumor of the bladder, and others. That's why it's very good methods. X-ray investigation, plain cystography or plain film QB. We can see shadows suspected the stone if we have radiopaque stone. This picture also very big stone. If we have non-radiopaque stone, I said we use a retrograde pneumocystography. First of all, we use catheterization of the urinary bladder, introduce 300 oxygens, and from the dark color oxygens, it's a dark color give for us, we can see shadow suspected the stone. Cystoscopy, very good methods, visual control, we can see what size, if we have complication or not. In this picture we can see a big stone in the urinary bladder. In this picture we can see benign prostatic hyperplasia, enlargement lobe, and complication small stone. White color is specific from the phosphate stone. Urate stone, it's a brown color and good consistency. Sometimes I said if we have foreign body, in these situations we have ligation stone. If the huge urinary bladder after gynecological operations, after oncology, if we have contact with the mucosa of urinary bladder and sutured by the non-absorbable material, silk, maybe love-sun, and others, after that we will have incrustations. Foreign body in the urinary bladder, after some period we will have incrustations and also stone in the urinary bladder. What treatment? Small bladder stones may be removed by the transurethral irrigations. If we have small stone, for example, in these situations, or if we have benign prostatic, maybe small stone less than 4 or 5 millimeters, maybe spontaneously after irrigations. Larger stone may be crushed by one of the variety or different manual lithotripsy and removed from the bladder by irrigations. We use ultrasonic and electrohydraulic lithotripsy, also laser lithotripsy, large bladder calculus. But sometimes we use open operations. In this picture we can see how we remove very big stone, because sometimes consistency the stones it's very hard. These operations we called cystolithotomy. We use midline incisions, remove musculus rectum, we open urinary bladder, remove a big stone, but after that we suture urinary bladder by absorbable material. Only absorbable. Now we use Vicryl, Dexone from the prolonged absorbable, because catgut only 5-10 days and they destroyed this material. We use synthetic absorbable material. If we pass drainage to the urinary bladder, it's called cystolithostomy, but without only cystolithotomy. In this picture we can see step by step how we use this operation, cystolithotomy. Incisions, it's Pfannenstiel incisions, urinary bladder, remove, and after that suture this bladder. Preventive treatment in calculus stone disease. I said from all my patients that if you have renal colic, if you have stone disease, this pathological from the all period of life. That's why we use prophylactics and metaphylactics, these pathologicals. It's dynamic visualizations. Every 1 or 2 times a year we use ultrasound examinations, X-ray examinations, urine, blood analysis, biochemical analysis. From the preventive treatment, In patients with the calculus stone disease, should be started with the conservative measure. Pharmacological treatment should be instituted only when the conservative regimens fails. Patients should be encouraged to have a higher fluid intake. We prescribe 2-3 liters from the prophylactic because concentrations of urea may be decreased. Also, in this picture we can see the following products have a higher content of oxalate. It's a fubarium, spinach, koa, tea leaves, and nuts. That's why from the prophylaxis we prescribe dietotherapy. It's also independent prophylactics and metaphylaxis is independent from the pH of our urine. Also, we prescribe not only fluid but also prescribe specific tier, herba tier from the prophylactics and spontaneously pass of the urea. We prescribe in Ukraine it's a chvosti, it's a kidney tier, Polpala, and other drugs. Also, we prescribe specific drugs have complex herba drugs. For example, Urolisan, 20 drops 3 times a day, Nephrodol, 1 table 3 times a day. In Poland country, we prescribe Urocept. In Slovakia, Cystonal. In Germany, Rovotinex. In the Germany, also Carnifrom, 1 tables or 20 drops 3 times a day. Preventive calculus stone, it's a vitamin C doses more than 4 grams per day can be taken without increasing the risk of the stone formations. Animal protein should not be ingested in excessive amounts. It is recommended that the animal protein intake is limited to approximately 150 grams a day. Also, I and my colleague, Urology, recommended different results from the good effects. In Ukrainian country, it's the results, it's a Truskavets, Schidnica, Sataniv, Husiatan, where we have good water type of naftusa from the prophylactics and metaphylactic disease. In a foreign country, it's maybe Baden-Baden, it's in the Slovakia country, in the Poland, it's a Krynica Zdrój and others. Preventive uric acid stone. It's below examples of blood rich in an urate. It's a cough, Timus 900 milligrams urate, liver. It's also decreased kidneys to 110 milligrams, 1 grams a day, and others. It's independent. Also, if we have urate stone, we prescribe specific drugs that change our pH. It's specific drugs. It's Blemoran, Uralid from the litholis. We will have litholis and also pH urea. Okay. In continuation of our lecture, I would like to say a few words about complications of urolithiasis. One of them is the hydronephrosis. What is it, hydronephrosis? Sometimes we call it hydronephrotic degenerations, hydronephrotic atrophy, the permanent progressions of dilatations of pelvic calical systems followed by the atrophy of the renal parenchyma and its dysfunctions caused by the urinary pathologic disorders. What's the etiological and pathogenesis? Hydronephrosis develops owing to construction of the pelvic urethral systems, high coming out of the ureter, construction of the ureter by blood vessels, embryonal vessels, abdominal enhancement, and others. Very often it's a congenital abnormalities, but sometimes after pyelonephritis, after some pathologicals, we'll have problem with the output of urine. Dependent on the reasons of development are different. Hydronephrosis caused by the obstacle of the pelvic or urethral segments, obstacle within the ureter, obstacle at the lower ureter, and neurogenital disorders. Muscular membrane hypertrophy and urinary bladder cavity dilatations. Sometimes without dilatation of the calico-pelvis systems, we have hydroureter. If we have dilatation only the pelvis, it's called pyloectasis. Sometimes we have also atrophy of functions layer of the kidney and very thinning parenchyma. In this picture we can see. Now I give you information. If we have dilatation the ureter, it's called hydroureter. And thinning parenchyma, dilatation the pelvis and calyces. The pressure within the renal pelvis is normally close to zero. When this pressure increases because of the obstructions or reflux, the pelvis and calyces dilate. In this picture we can see normal pelvis, normal upper, middle, lower calyces, but if we have problem with the output of urea, it's dilatations. We can see dilatations the pelvis, dilatations the upper, middle calyces. The degree of hydronephrosis that develops depends upon the durations, degree and site of the obstruction. In the early stage, the pelvis musculature undergoes compensatory hypertrophy in this effort to force urinary path to the obstructions. Later, however, the muscles become stretched and atonic. The progression of the hydronephrotic atrophy is as follows. The earliest change in the development of the hydronephrosis are seen in the calyces. The end of a normal calyces is concave because of the papilla that projects into it. With increased intrapelvic pressure, the formes becomes blunt and rounded. With persistence of the increased intrapelvic pressure, the papilla becomes flattened, the convex clut as a result of compressions enhanced by the ischemic atrophy. The parenchyma between the calyces is affected to a lesser extent. The change in the renal parenchyma are due to the compressions atrophy. In this picture we can see the renal parenchyma compression atrophy from the increased intrapelvic pressure activated with the intrarenal pelvis and ischemic atrophy. What classifications hydronephrosis? Hydronephrosis is primary or congenital and developed because of the congenital obstacle of the ureter. Secondary hydronephrosis arises as a complications in any disease, urinary stone of the kidney or the ureter, pedunculitis, tumor of the kidney. If we have problem with the output of urea, we can see the cause of this problem. Sometimes if you have stricture, for example, in the uretero-vesical junctions, we can see dilatation the ureter and calico-pelvis systems. Hydronephrotic atrophy may be uni or bilateral, aseptic and infected, open and closed and intermediate. Also, very important moment, there are three stages of this disease. First stage reflects pyloectasis, dilatation dust of the renal kidney within the moderate dysfunctions. If we can see dilatations only the pelvis, it's the first stage of the hydronephrosis. Second stage, prehydronephrosis. We can see hydrocalicosis. In this picture we can see. Without hydrocalicosis, in all cases, we have dilatation of the renal pelvis and calyces, thinning the parenchyma with the expressed dysfunctions. And the third stage is a hydronephrotic atrophy Atonic of the renal pelvis. This stage means the degeneration of the kidney into the great hollow sac with a fluid volume up to 2 and more. What is the main clinical findings? What the symptoms? It's a lower endocrine tract, urethra and bladder, hesitancy in the started urinations, lessened force and size of the stream, terminal dribbling, hematuria initial or total, banning on urinations, cloudy urinary due to complication infections, and acute urinary retractions. And first of all, if we have problem in the upper portion, in the kidney, ureter and kidney, pain in the flank radiations along the course of the ureter, gross total hematuria if we have stone disease, gastrointestinal symptoms, chills, fever, burning on urinations, nausea, vomiting, loss of weight and straight, and power are due to the uremia secondary to bilateral hydronephrosis. Because if we have problem from the both side, if we can see dilatation the calicopelvic system from the both, thinning parenchyma, in all cases we will have chronic renal insufficiency, and if we use biochemical analysis, the level of urea and creatinine increase. Sign: lower endocrine tract. Palpation of the urethra may be revealed in durations about the stricture. Digital rectal examinations may show atony of the anal sphincter, damage to the sacral nerve roots, or BPH or cancer of the prostate with palpable. Flow rate increase, and we have obstruction or weak distrusor functions. Because if we have enlargement, for example, benign prostatic hyperplasia, it's a problem with the output of urea, it's a reflux, it's a ureterohydronephrosis. Upper tract, an enlarged kidney may be discovered by palpation or percussions. Renal tenderness may be elicited if infection is present. A large pelvic mass, tumor, pregnancy can displace and compress the ureters. Laboratory findings. Anemia may be found secondary to chronic infections, or if we have chronic renal insufficiency. Leukocytosis is to be expected in the acute stage of infection. Little, if any, elevation of the white blood count accompanies the chronic stage. Microscopic hematuria may be indicated in the renal or vesical infections, tumor or stone disease. Past cells and bacteria may or may not be present. In the presence of the significant bilateral hydronephrosis, urinary flow through the renal tubule is slowed. Thus, urea is significantly reabsorbed by the creatinine is not. Blood chemistry therefore reveals a urea creatinine ratio well above the normal 10:1. If we use X-ray examinations, I said on all my lecture that X-ray examination will start from the plain film. On the plain film, very often if we have stone disease and complications of hydronephrosis, we can see shadows suspected the stone. For example, in this picture we can see coral stones situated in the right kidney. Sometimes we can see enlargement the shadow of the kidney. Maybe abscess musculus psoas if we have paranephrical problem. In this picture we can see shadow suspected the stones situated in the lower part of the ureter. Stone in the left kidney, and in this picture in the middle part. Sometimes we find metastasis that may be also problem the spinal cord damage, neuropathic blood, if they are osteoblastics, they are almost certainly from the cancer of the prostate. Next step, it's excretory urography. We studied anatomy function ability. For example, in this picture we can see small dilatation only the pelvis. It's called pyelectasia. It demonstrates this investigation's degree of dilatation in the pelvis and calyces and ureter. For example, in this picture we can see dilatations, pelvis and calyces. And in these situations maybe we have a problem with the output of urine. That's why we use a retrograde pyelography from the both sides, and we can see dilatations, ureter, pelvis, and calyces, and thinning parenchyma. It is the third stage of the hydronephrosis. For example, retrograde urogram may be show better detail than the excretory tubes, but if we pass catheter through the orifice to the kidney and introduce contrast material, we diagnose dilatations, calicopelvis systems, and thinning parenchyma. Problem in the lower part of the ureter. On the retrograde pyelography, we can see that in these situations we have problem in the lower part of the ureter. In these situations we have nephroptosis, moving the kidney, deformation the upper portion of ureter, stricture in the piloureteral segments, and dilatation the calicopelvis systems. In these situations, only indication to operative treatment without conservative, because only plastic operations and nephropexia. But in these situations, we can diagnose the problem in the lower part of the ureter, problem with the uretero-vesical junctions, only indication to plastic operations, resection the segments, and use, for my opinion, use ureterocystin U anastomosis. So sometimes we use a retrograde cystography because I said that may be problem in the lower urinary tract. For example, we use retrograde cystography. In this picture we can see different abnormalities, different pathologicals. For example, in the first picture, retrograde cystography, filling defect, right filling defect. It's specific from the benign prostatic hyperplasia. Retrograde cystography, filling defect non-irregular in the right part of the urinary bladder. We suspect cancer of the prostate. Maybe this cancer compress the right orifice and problem with the output of urea, and we will have ureterohydronephrosis. And if we plan resections of the urinary bladder, we maybe use ureterocystin U anastomosis. Retrograde cystography, enlargement urinary bladder, may be problem in the neck of urinary bladder, but also complications, vesicoureteral reflux from the both sides, and ureterohydronephrosis. In these situations, indications only to operations. And the same retrograde cystography, problem with the neck of urinary bladder, enlargement bladder, vesicoureteral reflux, and ureterohydronephrosis, dilatation the ureter, pelvis, and calyces from the both sides. Indication only to operations. Ultrasound examinations, very simple methods. We find what is the problem in the upper portion or in the lower portion. Non-invasive, very simple, but very good diagnostic. For example, in this picture we can see dilatation the calicopelvis systems. If you know normal our pelvis, for example, 2 to 1 centimeters, 2 to 2 centimeters, the parenchyma 16, 18, normal to 20 millimeters, but if the doctor gives for us information, the pelvis 5 to 6 centimeters, calyces 3 to 5 centimeters, parenchyma thinning, for example, 3 5 millimeters, yes, we suspect hydronephrosis. Also, without problem in the upper portion, maybe we find problem in the lower portion. For example, very enlarged benign prostatic hyperplasia, compress the intramural part of the ureter, problem with the output of urea, and will have ureteral hydronephrosis. Only after remove the benign prostatic hyperplasia we will have normal function of the kidney. That's why without conservative treatment, without invasive, only operative treatment. Endovesical examinations help to take correct diagnosis. Sometimes we find pathologicals that help to take correct diagnosis, I said. For example, stone disease. Stone situated in the intramural part of the ureter. We can see stone, dilatation, the orifice. Cancer of the bladder, compress the orifice. Tuberculosis, hyperemia, deformation, stricture of this part is also cause to the ureteral hydronephrosis. That's why the simple methods help understand what the cause of this hydronephrosis. CT give all very good informations. For example, normal parenchyma, you can see normal pelvis, but from this side we can see thinning parenchyma, dilatation the calico-pelvis systems. You see. Okay. Differentiated diagnosis, hydronephrosis with the pathological that simulates this clinic. But clinic in all urology symptomatic, it's very similar. If we have, for example, tuberculosis, sclerosis, hydronephrosis, cancer, pyloectasia, cancer of the middle part of the parenchyma, adenocarcinoma. In all cases, we have pain, we have problem with the urinations, we have in the urine analysis hematuria, leukocyturia, proteinuria. Only if we use additional investigations such as X-ray investigations, ultrasound, MRI, CT, endovesical examinations, we put correct diagnosis. Treatment. Treatment of the main cause of obstruction and stasis. We find what pathological. If it benign prostatic, cancer of the prostatic, neurogenic bladder, ureteral stone, posterior ureteral valves, and ureteral stenosis and others. Irradiations of infections. One of the obstructions is removed. Area 4 should be made to eradicate infections. If the infection has been severe and prolonged, antibiotics may be felt to sterilize the urinary tract. Because in all cases, if we have problem with output, we will have pyelonephritis. And if we have severe stage, in all cases, we prescribe desintoxicants, spasmolytics, antibiotics, the wide spectrum to the sensitivity. And treatment. I want to say that if we have first stage only pyloectasia, it's indication to the conservative treatment, prolonged visualizations, and others. But if we have second stage, if we have dilatations, the calico-pelvis system, pelvis, and calyces, it's indication to operative treatment. Operative treatment depends what the cause of this hydronephrosis. For example, in these situations, we have pedunculitis, maybe after pyelonephritis in the young period, complications, stricture the pyloureteral segments. That's why problem with the output of urea, dilatation the pelvis and calyces. In these situations, we plan operations. Maybe from the finger, from the Foley, from the Anderson-Hines and other, we use plastic operations. For example, in these situations we have additional vessels to the lower poles of the kidney. Sometimes it's a congenital pathological that cause to the hydronephrosis. That's why we plan operations antivesical anastomosis and plastic of the pyloureteral junctions. Very often, more than 70% of all cases, we use plastic operations that called by Anderson-Hines. What's the operations Anderson-Hines? We use a resection the pylorus, resection the segments, and formed new anastomosis and put drainage that called nephrostoma. So very often we use these operations. In this picture we can see classic Anderson-Hines resections, pylorus and pyloureteral junctions, and formed new anastomosis. Very often we use these pathologicals if we have problem with the pyloureteral junctions. Sometimes use modification operations Cap de Verde. In this picture we can see modifications these operations. Okay, now sometimes if we have a problem with the complication, the sad stage, it's indication to nephrectomy. If we have sad stage, thinning parenchyma without functions, that's why plastic not good from the prolonged period. It's indication to nephrectomy. We use these operations nephrectomy from the lumbotomy incisions, laparotomy incisions. Very often now it's modern. You saw from the film that use laparoscopic. Robert Da Vinci helped to take these operations. But in this picture we can see how we use open operations. First of all, it's the positions from the lumbotomy. Incisions between 12 and 11 ribs to the mesogastricle, open pararectum cavity, lumbotomy, revisions all kidney. After that, ligations, we put clamp to the arteria and vena renalis, remove the kidney, and suture by 3-layer, musculus obliquus externus, musculus obliquus internus, and musculus transversus. And also in all cases we put 3-4 drainage near the paranephretical fat in this cavity from the 3-5 days. Okay, I think you understand this moment. Thank you for attention. I wish you good health. Thanks.